So your post-op care will be checking for and monitoring circulation, motion, and sensation of the extremity distal to the vascular site. So let's say the vascular entry was the femoral artery on the left leg. So therefore, you'll be checking beginning from the left thigh to the knee all the way to the foot. So you'll be checking that. And of course, in order to have a point of comparison, you always check the other leg as well. Do they look the same? Is the other leg bigger than the other? Right? So you have a point of reference. That way you can always monitor for changes. Your number one concern, of course, is either bleeding or lack of circulation to the distal part. Because even though you put a stent, the stent is not clot proof. So there may be clots that could form on the stent, even though it was just newly put in. All right, let's go to DVTs now. So DVT is the number one please also read chart 636-5. These are what I mentioned. Here's CMS, circulation, sensation, and motion, and you have details here about what exactly to look for. So you're looking for color, asking the patient for pain, paresthesias. These are the, have you ever talked about compartment syndrome? I guess not. Okay, compartment syndrome will be discussed next semester under your musculoskeletal disorders under fractures. Anyway, so this is, because it's the same concept. If you have lack of circulation to an extremity, there will be 6 P's that will appear. The 6 P's are in response to a lack of either circulation, both in arterial as well as venous circulation. And when that happens, that means nerve impulses will also be affected. Yeah. So that's why the 6 P's will appear. This is, of course, an emergency. That means the extremity distal to the access site is could potentially suffer ischemia, and you could lose that leg once these 6 P's starts to appear. So when they appear, of course, you call the physician. And here is foot care. I think I mentioned this last week. This will be similar to the foot care you'll see later in chapter 64. We won't do the arterial problems here, including the aneurysms and aortic dissections. That we'll come back to chapter 36 in your 5th semester, because this is discussed along with stroke, because these are the causes of stroke, although these aneurysms here are referring to peripheral aneurysms, not in the brain, but it's the same concept. So we'll skip that for now. Let's go now to venous diseases. So sorry, I almost forgot. This is on the blueprint also. There's only 2, very short. There's 2 arterial problems here, Berger's and Raynaud's disease. Both have similar interventions because they are the same arterial problems. They have different causes though. Let's begin with Berger's disease. So the symptoms here, there is also claudication. The cause is unknown, but the only relatable risk factor is smoking. It's not definite because not all smokers get this. So this is the weird part of it, because it doesn't appear in all smokers. We've had people who've been smoking for 50, 60 years, and then yet they don't develop Berger's disease. Then we have young people who only smoke for 10, 20 years, and then they get Berger's disease. So the problem here is the patient goes into ischemia and necrosis. So the arteries here go they constrict. Okay, the arteries constrict, causing ischemia, and of course that will deprive the whatever uh, um, no extremity it is supplying. It usually involves the hands and the legs and all the way to the feet. So this will lead to ulcerations, gangrene. No, your fingers turn black and then they're dead. So the only recourse is amputation. Before that, hopefully, we will manage this. Of course, you encourage the patient to stop smoking because that is the only known risk factor. And then the patient will be put on calcium channel blockers in the Philippines. And then, of course, this will include ulcer care if there are ulcers on the hands or the legs or the feet. And these are your teachings. Number one, again, stop smoking, avoid cold, keep your fingers warm. The disease seemed to be aggravated by cold temperature. So not only during winter, but also when they go into cold rooms, for instance, like the mall, for instance, or if they work in the kitchen, they enter the freezer frequently. Um, some teachings here are regarding the treatment. So there is interaction with calcium channel blockers and grapefruit, if you remember this under hypertension. And that's about it for Berger's disease. Like I said, it's very short. Next is Raynaud's phenomenon. This is another arterial problem. Recently, I think it was 2018 that, no, it was last year because they graduated last year. Okay, so I think around spring or maybe summer, last summer. I had two students with Raynaud's phenomenon. They were sitting just a few seats of each other, and they were both having the same symptoms. They both shared. They're actually good friends. They have Raynaud's phenomenon. The cause is unknown. We don't know why, but number one symptom here is their fingers turn blue when exposed to cold or stress. So, but mostly cold. They also notice it in school during exams because that is stressful. Their fingers turn blue. All they can do is just wear gloves, keep their hands and fingers warm. That's pretty much it. But as you can see, management is and teaching is exactly the same as Berger's. So you technically still have to just remember the same. Okay, so Berger's and Raynaud's have the same management. They're only the pathophysiology is different. So in Raynaud's, this one is vasospasms, but they also resemble some signs and symptoms as those in Berger's disease. Raynaud's phenomenon is also known to occur with people who have rheumatoid arthritis or lupus. These are the only two. I'm not testing the others because they're not really common, but Berger's and Raynaud's are quite common. Let's go to venous disease now. The only one we're talking about here is DVTs. These are the problems. So you form blood clots, and we'll talk about why blood clots form. The other venous diseases are those with defective valves. Now, our valves, the only way blood returns to the heart is through muscle contraction and one-way valves. So the valves keep the blood from coming back down to your legs. So once your muscles contract, they squeeze the veins, and then blood is pushed forward up back to the heart, and then they cannot go back down because you have valves. However, when these valves are damaged by number one, smoking, hypertension, then that will lead to venous congestion now. That will lead also to chronic edema, and then now you have ulcers that will venous stasis ulcers that will eventually form, and then now you have chronic wounds. Um, and as stated here, though they're not life-threatening, but these ulcers that result from venous insufficiency are quite nasty. You don't die from venous insufficiency, but you may die from the ulcers that may become septic because they frequently get infected. These are chronic wounds, like I said. These take months, if not years, to heal. And if you remember the table comparing arterial, venous, and diabetic ulcers, these require this particular type of ulcer will require compression dressings, and the compressions are really tight, especially the Uno boots. Or lastly, skeletal muscles do not contract enough to return blood via the veins. So therefore, this would be common in people with limited mobility. And if you add obesity to the equation, then that will make it worse. So all of these will lead to venous congestion and of course edema. First, let's talk about how do we get blood clots. This will also be the same concept later when we get to chapter 32 under pulmonary embolism, because most pulmonary emboli begin as a DVT, although we do have cardiac issues like we already discussed heart failure, as well as dysrhythmias later in chapter 34. AFib or aflutter can also cause pulmonary emboli, but the number one most common cause are venous thrombosis, meaning DVTs from the lower extremities. How they form is from three things. So we call them the varicose triad. Can you see the whiteboard?
Yeah.
Okay. So we have three conditions here: endothelial injury. This is referring to vessel injury. So somebody who gets surgery, somebody who has trauma, for instance, or even a paper cut. All right. I'm not saying a paper cut will cause a blood clot, but I'm just talking about how blood clots form. So three conditions. There are three conditions wherein they can form. And hypercoagulability. Okay, so three conditions. Endothelial injury, like I said, is any vessel injury. You could have surgery, you could have massive trauma, for instance. So you have multiple vessels that are injured. So it doesn't matter if it's a capillary, an artery, or a vein. Endothelial injury will cause blood clots. The simple prick of a finger, let's say you check your patient's blood sugar, so you prick them with a lancet and then you get your drop of blood, so that will form a clot, right? Another condition how clots form is by venous stasis. So venous stasis will occur in, the recent example is in venous insufficiency. When you're immobile or sitting in for long periods of time, let's say you're taking a Greyhound bus from I don't know, California to Maine, for instance. Okay, so that's a long 3-4 day bus trip. So you're sitting for hours each day. So of course, you're not moving. So blood will pool in your legs. That could increase the likelihood of blood clots because the blood is hanging out in one place, and platelets tend to do that when they're too close to each other for a long time. They will stick to each other, forming a blood clot. So that will apply for people who have prolonged immobility, spinal cord injury, for instance, or just debilitation. You know, you have a old person um, just laying in bed, not moved, not turned, no leg exercises, so they can form blood clots. People in a coma, uh, people who are intubated on a mechanical ventilator, people who have long surgeries, okay, that could also be venous stasis, or any cardiac problems like AFib and aflutter, as I mentioned, or heart failure, for instance, heart failure exacerbation. So any condition that lets blood sit too long in one place, wherever that place is. Hypercoagulability. These are conditions. Examples are if you're taking oral contraceptive pills, for instance, because these hormones cause water retention and therefore increases the likelihood of um, venous stasis, and then you have blood clots forming. Others are cancer, for instance, that will also increase the likelihood of blood clots, sepsis, or severe infection. There are a lot. So we do have some examples in chapter 36. But anyway, basically, these are the three conditions wherein a blood clot will form. Just interrupt me if you have any questions. Okay, here is your Virchow's triad. So we have venous stasis, we have endothelial injury, and then we have hypercoagulability. They just jumbled everything in here though. All the three conditions are listed here. So the highest incidence are those who have undergone surgery. Highest especially are joint surgeries, hip surgeries, knee surgeries, because not only do we have decreased mobility there, but also not only clots can form, they can also throw fat emboli. If the cause of this hip surgery wasn't elective, let's say the patient suffered a fracture, for instance, then that would be on top of a clot, they may have a fat embolus as well. The rest are these ulcerative colitis. So this is hypercoagulability. This is venous stasis, hypercoagulability, hypercoagulability, and venous stasis again. I gave this as an example, okay, prolonged sitting for whatever reason. So you have plenty of opportunities here to form blood clots. Therefore, for all your hospitalized patients, give me one intervention to decrease the likelihood of blood clots.
Keeping them mobile.
All right, so if you can get them to walk, that would be great. Do not allow them to sit around unless of course they can't. Let's say it's a paraplegic. Okay, of course those people can't walk. However, for anyone who can't walk, then you can always do passive range of motion. You can always do leg exercises. So the idea is to keep blood moving. You don't want blood sitting around anywhere. So that's why some of our interventions here are, of course, we put on stockings. We'll get to that shortly. Since DVTs are fatal, then of course joint commission comes into the picture. You remember we had SKIP in chapter 14 for surgical patients, meaning Surgical Care Improvement Project, which is a core measure for joint commission. Here is now another core measure from joint commission, this time for VTEs or DVTs. So these are your measures, meaning the patients, all hospitalized patients must be screened for DVT risk. And then there will be corresponding intervention, preventive measures, and later, if they do develop one, then of course treatment. Here are other risk factors. They again fall under the three triad, the varicose triad. So these either form cancer is hypercoagulability, bedridden, that's venous stasis, major surgery, that's endothelial injury, etc. All right. So all of these um, increase the risk of DVTs. And you also have some of the symptoms here. Usually DVTs hardly form in both legs unless you are really unlucky. Um, Another is, remember in chapter 13 with the PIC line, we said PIC lines had a high risk for clot formation too, correct? The swelling here or the affected limb is usually one. And this is one of your signs. It's at least 3 centimeters larger compared with the other leg. So that's about at least an inch. And then there's edema in one leg. As you can see, it's usually only on one leg. Okay? It's hardly both legs. The history of having a blood clot increases your risk for another one, meaning how did you get a blood clot in the first place? That means you had one or more of these risk factors. That's why you had one. Those risk factors don't really go away. You can only control them. Each hospital develops their own DVT risk assessment. They usually contain one or more of the varicose triad, meaning if a patient's, a hospital's checklist will have one of these. Usually they have at least maybe 30 items on the risk assessment tool. And if it's not, it doesn't take much in order for a patient to be at risk. You only need a score of 2. Each of those factors is worth 1 point. So let's say age, for instance, usually most hospitals have age greater than 70. So if patient's 70 and then they have their surgical patient, for instance, there goes your 2. Smoking is another risk factor. So it's not hard to score 2. Almost everybody may score 2. Okay. Let's try. Mr. Christopher, do you smoke, sir?
No, I don't.
Do you lay down? Do you sit down for long periods of time?
I guess so. I work for like 3 hours or so
Okay.
at a time.
Okay, that's 1 point. Do you take oral contraceptive pills?
No.
You didn't have to answer that. Um, I guess you don't. Okay, so you only scored 1, so you have no risk. But think of a hospitalized patient, for instance. So remember, smoking is already 1 point. So once the patient has a secondary diagnosis, for instance, let's say they were admitted there for, I don't know, appendicitis. Okay, so that's already a, because that's one of the factors also. So you have you have a diagnosis that impairs your mobility. So there you go. That's 2 points already. And therefore, for every patient who scores 2 or more, you have to institute your interventions. There's a warning here about Homan sign. This was decades ago. We did used to use Homan sign as a indicator for possible DVT, presence of a DVT. Not anymore, because even now, if I dorsiflex my feet, I have pain in my calf already. So that means everybody would have a DVT then. So they're no longer relying on this. Was this discussed in fundamentals of nursing?
No.
Okay, good, because we don't do this anymore.
We discussed it.
Yes?
Yeah, they said it was not done anymore.
Okay, so you did discuss it and the teaching was not anymore, right?
Yeah.
Okay, very good. Because again, it's not reliable. So how do we diagnose a DVT? How do we know? So clinically diagnosed. So you look at the patient's symptoms, so you see swelling of the leg, which is not the same as the other leg, or the patient reports pain in the calf, or if it's a superficial, because we can have superficial instead of deep vein blood clots. Superficial, you see actual phlebitis on the course of the vein. So if it's a superficial vein, you can see redness along the course of the vein. Unless if it's DVT, then of course you won't see it, but the patient will feel it. They'll feel pain. So how we know is we have to find it. So once you have a diagnostic criteria, let's say you have clinical signs and symptoms, it could be a blood clot. You call the doctor, he orders a Doppler ultrasound. So we have to literally find it. So the ultrasound tech examines the affected leg with the probe, and then if she sees it, then there you go, you have a blood clot. Before that though, a doctor may opt for a more conservative approach. Before, let's say he looks at the leg, there's really no swelling, but then the patient reports pain, he can simply order a blood work. So a D-dimer test can be done. D-dimer is a fibrin degradation product. Some books say FSP, meaning fibrin split product or fibrin degradation product. Basically, a clot is made of fibrin. Let me show you a short video.
At the site of vessel injury, the first platelets arrive to start sealing the wound. Simultaneously, the coagulation cascade with its various coagulation factors is activated.
Can you see the video?
Yeah, we can.
Yes.
Hear the audio?
Yep, we hear it.
This involves two pathways, the extrinsic and the intrinsic pathway. Extrinsic activation begins with now exposed molecules of the vessel wall, such as tissue factor.
All right, so this every capillary, every vessel that is injured releases tissue factor. And tissue factor will activate the clotting cascade, meaning once they're produced by the injured vessel, platelets will be attracted to the area, and then that's the first step of the clotting, clot formation. However, this is only a temporary. So the extrinsic pathway will take probably a few seconds. Remember the last time you had a wound, so you cut, bled for a few seconds, and then it stopped, right? However, once you messed with the wound, meaning you moved it, you touched it, it started to bleed again. So that's proof that the bleeding stopped only for a while because you had a temporary clot, but it wasn't stable because it was only made of platelets. So the clot isn't stable. So we have to wait for the intrinsic pathway to finish because we need fibrin to be formed in order to stabilize the clot. So let's watch the rest of the video.
Which forms a complex with factor 7. Finally leading to the activation of factor 10. This factor 10A is the point at which the extrinsic and the intrinsic pathways of the coagulation cascade meet. The intrinsic pathway consists of various coagulation factors activating each other in a chain reaction. At its end, a complex with an additional cofactor is formed. This complex now activates factor 10.
Okay, so now you have, this is the extrinsic pathway, which stops the bleeding temporarily. And then this is now the intrinsic pathway, which takes several minutes before they can form fibrin. So once these two meet, then the clot after a few minutes will eventually be more stable and therefore will permanently stop the bleeding.
Since the two pathways merge at the level of factor 10A, this factor has a pivotal role in the coagulation cascade. Further down the cascade, factor 10A in combination with 5A activate thrombin.
Okay, so when we talk about heparin later, heparin is a thrombin inhibitor. It will stop this step right here. So it will stop prothrombin from catalyzing thrombin. So therefore, this step in the coagulation cascade is inhibited. So therefore, no further clots is formed. We can't do anything about the clot that was already formed. It's already there. But future clot formations will be inhibited by giving heparin. So this is where heparin acts. So by inhibiting the formation or the catalyzation of thrombin, then the rest of the cascade, which is now fibrin formation, will stop. All of those, no thrombin, no fibrin formation.
And induces the so-called thrombin burst. One molecule of factor 10A can catalyze the formation of 1,000 molecules of thrombin. These large amounts of thrombin cause the further activation of platelets and the enhanced formation of fibrin. Fibrin then forms strands, making up the mesh that stabilizes the platelet plug in an arterial clot and holds together the red blood cells in a venous clot.
All right, so you have there an arterial and a venous clot. Either way, there is fibrin involved. And then after this step, after a clot is formed, the next step of the body, because we have a clot formed, the body will now start dissolving this clot. That, of course, is called fibrinolysis. That's a natural reaction or the natural process of the body. Right after a clot is formed, it will slowly start dissolving the clot. However, that process takes several days to accomplish. So that's why in some cases, if the patient's clot is so big, that's such as in a pulmonary embolism, for instance, we can't wait for the body to dissolve it, meaning we will have to give the patient a thrombolytic, such as in stroke, for instance, or in an MI patient. So those are examples wherein we have to give a thrombolytic because, of course, the patient's dead if we wait for the body to dissolve the clot, which takes days. So, but the point here is using D-dimer. So we said that after a clot is formed, the body gets rid of it, right? The body will start dissolving that blood clot. The byproduct after you dissolve fibrin is D-dimer. So that means the more D-dimer you see in the bloodstream, the blank the number of blood clots. Anybody?
The less.
Again, fibrin is the one that holds together this clot, right? And then the body will start to dissolve that blood clot right after it's formed, which will of course take days. But once you start breaking down fibrin, what's left behind is D-dimer, meaning it's like after you burn something down and then what's left is soot or ashes. So the ashes here is D-dimer, meaning the higher your D-dimer, the blank your clots.
Lower.
D-dimer came from fibrin.
Increased.
Oh, increase, sorry.
The clots you have. So it is directly related to the number of fibrin that was formed. Okay, so meaning the more blood clots your patient has, the higher the D-dimer level. Is that understood?
Mm-hmm.
Yes.
So you use therefore D-dimer as, I'm not saying you use it to diagnose a blood clot. I'm just saying, can you use it to rule out a blood clot?
Yes.
Yes.
Yes. Okay. So the doctor orders a D-dimer. Let's say he's conservative, doesn't want to waste uh, money on venous ultrasound. So he'll order a D-dimer first. That only takes a couple hours to come back, and then it's negative. I mean, negative, and there's no blood clot, right? But if it's positive, then he sends the patient down for an ultrasound. Now let's go to interventions. Let's start with prevention first. So these are our, because it's not that easy, and sometimes the patient is not that lucky that the DVT stays as a DVT. Sometimes it breaks off, becomes PE, kills the patient. So it's better to prevent it because we may not be lucky to find it as the clot as a VTE. It may be already a PE by the time we discover it. So like I said, prevent it first. So always assess your patient for the risk for VTEs and then start. So ambulation, leg exercises, compressions, stockings, or those compression devices. And if needed, or if the patient can't do ambulation or exercises, then add anticoagulant therapy. Somebody read this, please, because in the olden, during my time, I shouldn't say olden, older, but during my time, we put the patients on bed rest once we have a DVT as a diagnosis because we were afraid that ambulation will dislodge the clot, and now the patient has a PE now. Somebody read this, please. Miss Manara.
Supportive therapy for DVT has typically included bed rest and elevation of the extremity. However, research shows that ambulation does not increase the risk for pulmonary embolus.
Continue, please.
Sure. The risk of pulmonary embolism, PE, associated with more aggressive activity is unknown. The accepted approach is a gradual increase in ambulation as tolerated by the patient. Allowing patients to ambulate may decrease their fear and anxiety about dislodging the clot and life-threatening complications.
All right, so this is evidence-based. Based on research, there's really no evidence that ambulation dislodge the clot and cause a PE. However, I would feel more confident with this if we have anticoagulation already on board. Meaning, of course, after a diagnosis of a DVT, the doctor orders anticoagulants, right? So once we administer anticoagulants, heparin specifically, you saw already the clotting cascade that if we stop thrombin from being formed, then there will be no fibrin formed. So therefore, no blood clot. Like I said, the patient already has a blood clot. Our goal here is to keep that blood clot the same size. So by giving heparin, a thrombin inhibitor, it will stop further formation of other clots, as well as the existing clot will not grow any bigger. Because remember, if you saw the animation, once a clot is formed, it will activate more platelets. So therefore, if you stop that process, so therefore the clot will remain the same, meaning you can stabilize the clot and then allowing the body to just dissolve it. So as you can see, we typically do not give thrombolytics for DVTs. We just leave it for the body to dissolve. The important thing is we stop further clot formation and further increasing of the size of the existing clots. Elevate the legs, of course, that will decrease the edema as well as promote venous return. That way we don't have any venous stasis. One thing we don't do is massaging, right? Definitely no massaging the affected leg. You can do intermittent or warm, continuous warm soaps. That's fine. The stockings are fit the right size for the patient, so don't force a small size on a plus size patient, right? We have measurements. The package of the stocking has instructions on how to measure the size. So you just get a tape measure, and then if your patient's calf circumference is a certain range, so you have a reference on the package as to what size the patient should have. So anticoagulants are our choice. First thing is always IV heparin. So one of the math exams next week will be, of course, heparin calculation, both for bolus as well as infusion. So please review NUR 103 for if appropriate, the patient may also be put on low molecular weight heparin. Low molecular weight heparin is weight-based, so therefore no need to monitor PTT, unlike IV heparin. Or we can use novel oral anticoagulants. These we'll discuss each one shortly. All right, let's start with IV heparin. The purpose of heparin is to prevent the enlargement of an existing clot. It has no effect on existing clots. It can only keep the existing clot from getting bigger. And we just leave the body, our body will naturally dissolve the existing clot, which again takes several days. We do monitor PTT for heparin, that is the bleeding time affected by the drug. This is the standard dose, so it's about 80. Usually most hospitals I work for use 80. It's 80 units per kilogram. So you need a accurate weight for the patient and do your calculation, and that's your initial. The protocol, the sheet will also tell you how much bolus to give. Let's say 80 units per kilogram bolus, also depends on the facility. You'll discuss the complications. HIT is chapter 40. These are blood disorders, bleeding disorders, and clotting disorders are in chapter 40. I'm not testing it right now. It's a long story and we don't have time. But just know that anyone who's on heparin, you should monitor the platelet count. If the platelet count drops by 50%, then you have to stop heparin. Of course, we can't do that. We have to notify the physician first, and then he gives you the order to stop heparin because the patient may have heparin-induced thrombocytopenia, which can be deadly. This condition is increasing now because we're using heparin a lot more, so more and more patients are developing HIT. However, since the patient has a blood clot, needs heparin, but we can't use heparin, obviously, we use this one instead, argatroban. That's an alternative. It's still a direct thrombin inhibitor, but highly selective. And it's not heparin, so it's safe to use. Here is your best practice. Any patient on anticoagulants is on bleeding precautions. Let you read that on your own. Monitoring for bleeding, looking for having your antidote ready, and what to teach the patient to avoid bleeding. Low molecular weight heparin. It is still heparin. However, unlike unfractionated heparin, which can be given IV, low molecular weight heparin is only given sub-Q. So therefore, it's not as fast-acting compared to unfractionated heparin, because of course this is subcutaneously administered, whereas your unfractionated heparin is given IV. So the moment it hits the bloodstream, anticoagulation starts right away. Like I said earlier, unlike unfractionated heparin, wherein you have to monitor the PTT every 6 hours, the whole entire infusion. The low molecular weight heparin is weight-based. It's 1 milligram per kilogram. So therefore, since the dose doesn't change anyway, so regardless of what the PTT says, the doctor won't adjust the dose because it's weight-based. So therefore, why check the PTT in the first place? Does that make sense?
Yes.
Okay, because unlike unfractionated heparin, because the dose, the infusion rate will change depending on the PTT. Meaning, if the PTT is so high, we decrease the infusion. If the PTT is so low, we increase the infusion. Make sense? So it's continuously adjusted. However, for low molecular weight heparin, since the dose is fixed based on the patient's weight, so no matter what the PTT says, whether PTT is low or too high, we can't change the dose. It's because it's weight-based. So better not, no, why monitor PTT? However, before the doctor decides to use this instead of IV heparin, is already calculated, meaning they already decided that the patient's DVT is stable and it's a low risk DVT, meaning the clot is tiny, okay, tiny enough, not not really fatal to the patient. It's not that high of a risk, so he'll just put the patient on low molecular weight heparin. Warfarin. Please read this part. All patients who are receiving unfractionated heparin will have warfarin at the same time, because we cannot keep the patient on heparin forever. We have to discharge this patient. We can't discharge them on an infusion of heparin. So they have to be on oral anticoagulant. However, because of the action of warfarin, which is a vitamin K inhibitor, it's not like unfractionated heparin, which is a thrombin inhibitor. Now, vitamin K was not mentioned anywhere in the video we watched earlier. Vitamin K is needed. Have you discussed this in peds yet? Why we give vitamin K to newborns?
Aiding gut bacteria.
Not really, it's right here. So you need vitamin K in order to produce clotting factors. Warfarin is a vitamin K antagonist. So therefore, if it inhibits vitamin K, can you produce clotting factors?
No.
No. So this is where warfarin works. However, warfarin has no effect on existing clotting factors already in the plasma. So once you give warfarin, warfarin starts inhibiting vitamin K synthesis today. However, it takes about 3 to 4 days before the body gets rid of the existing clotting factors already in the plasma. So we have to wait until all those clotting factors are gone before you see the effects of warfarin. Does that make sense?
Yeah.
Yeah, so that's why you won't have the effects of warfarin today. It would be about 3 to 4 days, because again, warfarin will only affect future formation of clotting factors, but not all though. There are only 4 vitamin K dependent clotting factors, meaning the patient will still have clotting factors, others, but these 4 are enough to be inhibited. That way you have less likelihood of clot formation. So there's an overlap, because unfractionated heparin gives you anticoagulation right now. So the moment you start infusing it, the patient is protected from further clot formation. And then you also start the warfarin today. Again, there will be an overlap, so the patient will be on both heparin and warfarin at the same time until the INR reaches between 1.5 to 2. Okay, so we monitor INR in warfarin. Once our INR is 1.5 or higher, then we can stop heparin, patient can go home. They can go home on warfarin. Okay, no need for heparin anymore. So basically, we want to discharge the patient on anticoagulation, but until warfarin starts working, we have to use heparin. All right. Any question on the therapy?
No. So heparin is short-term use always
Yes.
in that situation.
Yeah, very good. In fact, heparin has a short half-life. So let's say we go the other way. If this patient's already on warfarin, okay, and then they suffer something, they need surgery. Can we do surgery right now with them taking warfarin?
No, because 3 to 4 days.
Right, so it will be high risk, right, for bleeding. So what we'll do is take the patient off. We'll admit the patient to the hospital. However, we can't do surgery yet because the INR is still high. So what we'll do is stop warfarin. But remember, the patient needs anticoagulation because for whatever reason, maybe they have a fib or whatever the reason was they were taking warfarin. So what we'll do is stop the warfarin because it's harder to control warfarin. It takes several days, right? Heparin, however, can easily be stopped and started. 1 hour after stopping heparin, the effects are gone. So therefore, we'll stop warfarin. However, remember the patient needs anticoagulation. So we'll put them on heparin instead until the INR goes back to normal, and then the patient can go to surgery. So about 1 hour before surgery, the doctor will order heparin to be stopped. Patient goes to surgery. A few hours after surgery, we resume heparin. And when it's safe, patient goes back to warfarin and is discharged. Does that make sense?
Yep.
Any question? Okay, so the antidote for warfarin is vitamin K. It's called Niphytin. And here are your foods which are rich in vitamin K, because it doesn't make sense taking warfarin but then eating the antidote at the same time. Take note though that the dark green leafy vegetables here, it doesn't say stop eating them. Okay, it just says avoid, meaning you can still eat them, however, at smaller servings. Okay. Before discharge, of course, in the hospital, we have handouts about how much they're allowed to eat, meaning there's an equivalent. So let's say for Brussels sprouts, which are very high in vitamin K, you can only eat, a few pieces, let's say. But there's a guide for the patient to follow. Novel oral anticoagulants. So you've seen these on TV. Patients with a fib, for instance, not caused by a valve problem, can take these. What's nice about these drugs is no routine blood testing, no diet restrictions. They can eat whatever salad they want. There's no monitoring for blood work. However, not all of them have antidotes. We do have dabigatran, and this is the antidote for dabigatran. The others, apixaban, rivaroxaban, edoxaban, do not have existing antidotes. So you can already see what could be a potential problem here. A patient may have bleeding and then there's no way to stop it. And that's why you have lawsuits on TV about you or a loved one been taking Xarelto and suffered bleeding. You have a right to monetary compensation. Thrombolytics, like I said, is not routinely given for DVT. So let's skip this part. There is a surgical option. This is only for large blood clots. Then we have to do thrombectomy. So literally the doctor will go in, vascular surgery, remove the blood clot. Or if the patient has a contraindication for anticoagulants, so we can't use it, or there's a high risk for bleeding. Let's say the patient's too old, over 80 years old, has a history of has a peptic ulcer, for instance, then high risk for bleeding. They can't put them on anticoagulants. They'll do a implantation of a filter instead, an IVC filter. So this is a um, device implanted in the inferior vena cava, which is designed to trap blood clots until the body dissolves it. So they trap the emboli. It's like a spider web, okay, the shape of a umbrella. Okay, the sticks of an umbrella. You know umbrella. They have arms, right? The umbrellas have tentacles. So it's that, and they implant it in the inferior vena cava. So all blood clots returning to the heart will be caught in that spider web. And then
So how long does that take to dissolve?
several days, but it's, you know, don't worry, it's not going to go anywhere. It's going to be trapped by the IVC filter. It does have a 2% failure rate, because what if the blood clot forms above the body and not below? Huh? There's no superior vena cava. They only have one for the IVC, inferior vena cava only. As far as prevention, so you, of course, counsel the patient on preventing further DVTs, risk factors you already saw earlier. On top of that, though, of course, teach the patient bleeding precaution. We already have a chart earlier on your teaching for bleeding. Here are the foods that are high in vitamin K. So you only eat small amounts of this. This is not a everything. Okay, there are many more. As you can see, they only have food. There are beverages as well. There are also like cranberry. Cranberry juice is high in vitamin K. So you have drugs here also that should be avoided because they interact with warfarin. And that's it. I'm not testing the venous insufficiency, just the ulcers. And for venous insufficiency, these are the stockings, the compression, which was again mentioned already in the table under the, sorry, I do test this, I remember. There is a question on this one, how to apply the compression stockings. The instruction is not to bunch it up. It's better if you apply it early in the morning before you get out of bed. So you could be applying it with your leg up and then apply it. The easy thing to do is to put a, can you imagine using a Ziploc? Because these things are very hard to put on. They're so tight, and you know, think of a really edematous leg and then try applying this really skinny stocking. So it's better if you put, it'll be easier if you put a Ziploc bag over the toes, because that's really where the stocking gets trapped. So if you put a Ziploc bag over the toe and then slide the, of course the Ziploc bag is cut, okay? Because otherwise you can't take it out. So you cut the end of the, no need, because the stocking has a hole at the tip. So no need, I remember. So you put the Ziploc bag on and then you slide the stocking over. It'll be the easiest way to put these things on. Do not push them down because they will make your legs look like the Michelin Man. So you'll have bunched up, you know, areas. So you know what I mean, right? It'll make your sausage. Right? So don't do that. They should be put on one time and then you take them off at the end of the day. All right, here are do's and don'ts. So no crossing your legs. Okay, no restrictor pants. This is the UNO boot mentioned in the table. And this is definitely, oh no, here. So when you put them on, so I mentioned put them on before you get out of bed and then remove them just before going to bed at night, because otherwise you can't sleep. These are tight and they will keep you up. They're painful. I'm not testing varicose veins. All right, take a break. Come back at 9:20 for diabetes.
Okay.